Hello, I am Reem Abushar, and I would like to give you a brief overview of our article, Lay People's Ethical Attitude to Placebo Treatment, a Q-Methodology Study. In this article, we explore lay people's ethical attitudes in regard to the acceptability of treating conditions that have no or inadequate therapy by physician-prescribed placebos. Placebo treatment is used for various reasons, including complying with patient and family expectations, satisfying their demands and avoiding confrontation, exercising kindness and compassion, managing clinical uncertainty, and taking advantage of the placebo effect in reducing suffering. The placebo effect is associated with both pharmacologically active and placebo interventions. Placebo treatment usually involves some degree of deception and thus conflicts with the ethical principle of respect to person, which includes the right to autonomy, the right to be treated with dignity, and the right to know. The main aim of the study was to explore lay people's ethical attitudes toward the acceptability of treating conditions that have no or inadequate therapy by physician-prescribed placebos. Specifically, using averaging analysis and Q methodology, we explored how laypeople balance the ethical principles of respect for autonomy, beneficence, non-maleficence, and justice, and how other ethical approaches, such as feminism, communitarianism, and virtue, shape their attitude. To execute this study, 187 respondents rank-ordered 42 opinion statements that covered major ethical principles on placebo treatment according to a 9-category symmetrical distribution. Respondents were instructed to rank the Q-set statements along a continuum from strongly disagree to strongly agree and to comment on their extreme choices. We analyzed statement scores using averaging analysis and by-person factor analysis, also known as Q methodology. Our data support 3 main conclusions. First, on averaging analysis, patients' beneficence, or consequentialism, followed by physician's intent, or virtue, were more important than deception, or respect to autonomy. It appears that in the setting of patient-physician relationship and placebo treatment, non-lying deception and outright lying are not on the same footing, and information management may be acceptable. Second, the 4 principles of principalism may not be adequate when it comes to characterizing lay people's moral attitude to placebo treatments. Third, Q methodology identified various ethical attitude models that were mostly multi-principled, partly associated with respondents' demographics, and partly concealed in averaging analysis. This indicates that laypeople differ in how they balance various ethical interests to reach their individual points of ethical equilibrium, and that a one-size-fits-all approach may not be applicable in this context. For example, Figure 3, seen here, shows placebo treatment-related ethical attitude models in women. Interestingly, in women, there was a significant association between model type and major religious affiliations and place of education, but not nationality or occupation. We found that the majority of Christian women loaded on a family and deception-concerned model, while the majority of Muslim women loaded on a common good-concerned model. Figure 4, shown here, shows placebo treatment-related ethical attitude models in men. In men, there was no significant association between model type and religious affiliation, place of education, nationality, or occupation. However, the majority of Christian men loaded on a deception-concerned model, while the majority of Muslim men loaded on a motives-concerned model. In conclusion, the placebo effect importantly contributes to the success of pharmacologically active and pharmacologically inactive treatments. The underlying ethical reasoning explored in the current study can be used to identify people who would accept placebo treatment and to improve the acceptability of placebo treatment for people who don't.